certified family doctor. That has been my day job for over 10 years, and it's only been the last 2.5 years that I've been the chief medical officer of Vireo Health. So the first time in my career, I'm biased. I work with a company that grows, produces medicine, and distributes medical cannabis in Minnesota and New York. So take my talk with a grain of salt, but in my heart, I'm a family doctor and just am absolutely moved by what I've seen with medical cannabis. And so when I get the opportunity to share that, even across the border in Connecticut, I'm happy to do so. First thing I ask, in being a family doctor and my background is in integrative medicine, I've dealt with stigma quite a bit, but I've never seen so much as there is with medical cannabis, or what many call marijuana. You can imagine what this term brings to light for most patients and providers when we speak about this are a lot of words that aren't so pretty and things that we don't like to talk about. When I give my talk, I just like to call attention to this. Let's take a step back and let's treat this potentially as a medicine from an objective viewpoint. And I just told you that I'm biased, but I'm going to try to present an objective viewpoint about this as a medicine. And this is a quote from not the most medical context in the world, The Economist, but really puts a lot of things together that I've seen in the last 2.5 years as I've studied thoroughly medical cannabis and learned a lot more about this. If we were to suddenly discover this in some remote mountain crevasse, this would be hailed as a medical breakthrough. It's really amazing the number of diseases that this can treat and the endocannabinoid system that it harnesses, which I'll talk a little bit about. A little bit of a historical background. I've done a fair amount of work in ethnobotany, mostly in Palau in the Pacific Ocean. But never have I seen a medicinal plant that has such an intimate relationship with us as humans. And it's just an absolutely fascinating plant. This is a plant that has more than 60 unique compounds. Those are, chemicals that within this plant that exist nowhere else, that have a unique ability to alter biochemistry in human beings. And there's more than 500 of them in this plant. The one that we all know about is THC. Guessing everyone here has heard of THC. And THC is one of 2 major cannabinoids, right, within this plant. As I said, there are 60 plus cannabinoids as well that most of us know because it makes you high or it's intoxicating. And what we don't talk about are all the other chemicals that are present in this plant. The other major cannabinoid is CBD. How many of us have heard of CBD? And again, I've been doing this for about 3 years in my career. When I asked that question 3 years ago, maybe 2 hands went up. And so things are certainly changing. CBD is a major cannabinoid that's non-intoxicating. The theories and in vitro studies show an anti-inflammatory effect, and we use it, and has gotten the most press for treating epilepsy in children with intractable seizures. Medical cannabis dates back, as far as 2900 BC, some estimates more than that. But so this has been a rich part of our pharmacopoeia for thousands of years, and utilizing as a medicine as far back as 2700. And again, there are different estimates with that. But many call medical cannabis the Canis lupus familiaris of the plant kingdom. And like dogs, it's followed us all over the world. And the reason being not only for its medicinal benefit, but also its nutritional benefit, high in omega-3 fatty acids, and using the fiber. So the fiber is utilized in textiles and in many different areas, and it's a plant known as weed because it can grow in areas where weeds grow, grows very quickly, and can be utilized in many different ways that are advantageous to us as humans. So in medicine, amassed by many physicians, we have THC, right, already present in medicine, and this is Marinol. If anyone is familiar with this, this was FDA approved 1985, I think, for nausea and vomiting related to chemotherapy. But the difference between this and what I'm speaking about today, which is a whole plant extract, is this is a single synthetic biochemical agent. So it's a synthetic THC. Again, THC being a phytocannabinoid that's produced by the plant that interacts with our endogenous system, but this is a synthetic form of it, and only one cannabinoid of these multiple cannabinoids that are present in the plant. One of the main reasons that this hasn't been utilized so much in medicine commonly is a high rate of adverse events. And this is debated, but certainly is something that anyone that's utilized this medicine in their practice has seen that most patients don't tolerate this very well, and especially at the dose that it's recommended at. One of the things that is being argued, and this is debated, but is the thought that these multiple cannabinoids and the many other chemicals present in this plant are going to have a very different therapeutic effect within the human body. This has been termed the entourage effect, or which is a fancy term for synergy. Synergy is that thought that the whole is greater than the sum of the parts. So if you try to pick out one little piece of that, it's not going to have the same effect as many of these chemicals together. And what fascinates me about this plant is this idea of, in the human body, when we talk about health, is homeostasis. And even these two major cannabinoids that we discussed, THC and CBD, have a natural antagonism. So within the same plant, the two major components antagonize one another. And so we know of THC that it can produce euphoria. In higher doses, it can trigger anxiety and even psychosis, cognitive impairment, and a rapid heart rate. And how fascinating that this plant that has co-evolved with us for tens of thousands of years within that same plant has a major cannabinoid that has the opposite effects, which are no less euphoria, anti-anxiety, antipsychotic, neuroprotective, and bradycardia. And the thought is, and there are studies that back this, and I'll try to get into this a little bit more, is that loss of antagonism, meaning if you just pull one of these out and treat the human body with it, will lead to increased side effects and poor tolerability. And this is just a list of some of the other chemicals that are present in the plant. It's a pretty smart plant to create everything from cannabinoids to minor cannabinoids, terpenes, carotenoids, fatty acids, sterols, vitamins, and triglycerides. And this is a slide of the endocannabinoid system. Everyone's heard of the endocannabinoid system. This is something in medical school that I wasn't taught about at all. And this is an endogenous homeostatic system that can affect diverse processes in the body, from bone stimulation to immunosuppression to anti-psoriatic, anti-diabetic, anti-proliferative. This is just a fascinating endogenous system that when we utilize phytocannabinoids, the cannabinoids that are present in the plant, it engages this natural system that already occurs in the body. And the endocannabinoid system is known and has been studied to be thermoregulatory, changing temperature within the body, regulation of perceptive, cognitive, and motor functions, suggested roles, synaptic plasticity, brain development, hypothalamic hormone secretion, analgesics, so release of dynorphins, and affecting blood pressure and heart rate. It's a ubiquitous system that's present in the body, having multiple effects. And we talk about pain, right? I mean, what a fascinating system of how pain works. And, you know, and the little that I do understand of CRPS is the unknown etiology. And there are many things in medicine that we don't know, but we try to approach these from an evidence-based model and finding things that do make sense in the treatment. And we do know, in terms of the endocannabinoid system and pain, that there are similar locations to opioid receptors. That's periphery, the sensory neuron transduction pathway, and the descending modulatory pathway, with one huge difference, and that's an absence in the brainstem, which for us as physicians means that it can't shut down breathing. And that means that the side effect of potentially dying during sleep is not present with medical cannabis. And we do know, as studies move forward and we elucidate the endocannabinoid system and the presence of endocannabinoids in our blood, that there are certain diseases that once were termed black box, or we didn't know the etiology, that potentially could be explained by a clinical endocannabinoid deficiency. And, you know, top of this list is migraine, and that there was a study, a very fascinating study, where they looked at levels of endocannabinoids in the cerebral spinal fluid. That's the fluid that bathes the brain. And it was shown a statistically significant difference between migraineurs, those that suffer from migraines, and those that don't, with lower endocannabinoid levels. And we're starting to see more research related to fibromyalgia, causalgia, as was discussed before, PTSD, bipolar, autism, epilepsy, and neurodegenerative disease, of a potential endocannabinoid imbalance or deficiency. This is fascinating for me, that in this area where a lot of times we'll see at the dispensary, or oftentimes even my own practice, I'll see those patients that are intractable, right, that have tried everything under the sun. There's a potential etiology that hasn't been discovered and that we're deciphering. I'm going to talk a little bit about, in my experiences mostly in New York and Minnesota, and I apologize that I don't have much experience in Connecticut. But I'll talk a little bit about medical cannabis in the United States and New York specifically, but we're seeing a huge push. 28 states, 29 states now, over 2.6 million patients are using medical cannabis as a therapeutic option to treat their disease. And this is legally, right? So this is the tip of the iceberg. And there are additional states that have some aspects, and a lot are looking at CBD as a potential treatment for epilepsy and other diseases as well. I try to make it a little bit fun with pictures, so it's not all business once in a while. It's a gorgeous plant, and it's just we think of it with this negative connotation, but it really is an amazing plant to work with. In New York and Connecticut, anywhere in the United States, as providers, as physicians, nurse practitioners, physicians assistants, we can't prescribe medical cannabis. It's called recommending, because on a federal level this is still an illegal substance, and that protects us and our DEA number by not prescribing it, by recommending it. These are the qualifying conditions in New York. I apologize, I did look quickly at Connecticut, that there is certainly overlap between these, but these are severe debilitating diseases. And as I've been working with this for 2.5 years, in our dispensary I've had more interaction with CRPS patients than I have in my entire career as a family doctor. And that is because these oftentimes are the intractable patients that have tried everything under the sun and are using medical cannabis as a last resort. In New York, this was most recently added. Chronic pain, which you could imagine, opens the door quite a bit for patients that can utilize this as a therapeutic option. In New York, you have to have a accompanying symptom as well. But these are some of the things that I think are key about a medical model revolving around medical cannabis, and that is that it's licensed pharmacists that dispense it, that it's extracted through CO2, which we think is one of the safest forms of extraction, that we have a formulation or a real dose. And this is one of the things that really got me involved in as a physician. In New York, we have third-party testing by the Department of Health that we have to have within 5% of that stated dose. So that means if we say there's 2.5 milligrams of THC and 2.5 milligrams of CBD, we have to have within 5% of that stated dose in order for that product to be able to dispense to a patient. Most medicines have a 10% window, so this is even more strict than most medicines will find in a pharmacy. And this is what I think is absolutely key, that if a patient comes and does receive some benefit, or even if they don't, to be able to titrate that medicine, and also to be able to give that same medicine if you come back in 2 weeks. And this is something that I think is a big difference between programs out west and programs in the east here, like the New York program. That's precision of that final product, that there is third-party testing. Anyone that explores medical cannabis as a therapeutic option should absolutely make sure they see third-party testing, that there aren't heavy metals, bacterial, fungal elements, that there are what's stated in that medication. And there aren't popularized names and strains, no advertising, and a number of conditions that are relatively severe that qualify someone. Anybody know what this is? Any guesses? This is a magnification of the flower bud of the cannabis plant. These tiny little balls here are called trichomes. These are the factories on that bud that actually produce the oil that is then utilized to make the medicine. So these little factories on the magnified bud here are where the oils are produced with all those chemicals that are utilized as medicine. There's kind of a magnified view of that trichome. And this is just a process of kind of what happens with cultivation, extraction, formulation of an actual medicine, that packaging and a distribution to a patient. And again, just talking of that difference, and it's not that I'm an enemy of programs out west, it's just as a physician, if I get Michael Phelps, that doesn't mean a lot to me. Or if somebody gives me a purple gorilla, I don't really know how to titrate that. I don't know if I'm getting the same product if I come back 2 weeks later to treat my very severe disease. And I want to know what's in there. And that's the idea of creating a medicine that has the milligram active cannabinoids listed on the side, that's third-party tested, that we know is safe. And to distribute in a place that feels comfortable. There aren't bongs on the shelves or neon lights, that feels like a doctor's office, and you can speak with a New York licensed pharmacist and discuss what might be your treatment regimen. And this is something that we've created, we call a spectrum, to make sense of cannabinoid-based medicine. And this means that we have varying ratios of THC and CBD, along with all those other chemicals and constituents I talked about, but there are differing ratios that treat different diseases. And as you saw the disease states, they're very different. Most patients will start in a green ratio, which is a 1-to-1 ratio. And an example is we create a capsule that's green and has 2.5 milligrams of THC and 2.5 milligrams of CBD. That creates a very structured backbone from which to either titrate up, titrate down, or shift. I think there'll be discussed a little bit more the science behind the treatment of neuropathy. Most of the science has been with THC. Right? So a patient that doesn't respond to a one-to-one may move in that direction of a higher THC dominant strain. And again, coming in the form of a medicine. But this gives us a backbone to discuss medical cannabis in a logical fashion and titrate patients in a way that makes sense. And these are the forms that are allowed by law in New York, from capsules to a vaporized form, the benefit of that being a real quick onset of action. The capsule and the oral solution will have a slower onset of action but will last a longer period of time. And an oral oil that you can actually titrate very closely to 0.05 milligram major cannabinoid if you need to. And the major differences of these are onset of action and how long they're going to last. With the oral solution and the capsules lasting the longest, a lot of patients utilize this to not only alleviate their symptoms, but to help them get sleep at night. This is beneficial to take at night, as opposed to something, wow, I feel the snow coming, I need quick onset and need something to kick in quickly as a PRN, but it won't last as long. So to get on top of it with a longer acting solution. I don't know how much time I have. I've got way too many slides. I get really excited and I just keep going. This was actually developed by one of my mentors. I grew up in Wisconsin. Dr. David Rakel developed this. And in medicine, we're real excited about SORT and evidence-based medicine. And this is, what is the research that proves a medicine or a treatment is efficacious and it works in patient? And that's my mantra. I'm a board-certified Western medical doctor. That is my mantra as well. I think one thing we don't look at enough is the other side of that. And so Dr. Rakel created a kind of a schema that is the strength of evidence, or that evidence that something works, but also taking in mind harm grading, right? And so example is exercise and diabetes. There are a few that will argue this won't benefit a diabetic to exercise a little bit more, and the potential for harm is incredibly low. Opioids in chronic pain are falling much lower, as we're seeing there is tremendous evidence for harm, including death, and not very good evidence that they work in chronic pain. And this is something that I hope that we start to discuss a little bit more within the medical field, is looking at not only that potential for benefit, but that potential for harm. And these are just grades of evidence. I'll skip through these a little bit, but we should have those same levels when we're deciding, and I encourage all my patients to think about this as well. What is that potential evidence for harm when I'm weighing these therapeutic options? And as physicians, we're caught in the middle. We would love an alternative to opioids for chronic pain, but oftentimes there isn't that, and I can say that as a busy primary care doctor as well. When a patient reaches my door, oftentimes many of the over-the-counter remedies have been tried, and a lot of the other therapeutic modalities are now available. And so most people ask me, and physicians especially, will show me the evidence for medical cannabis in the treatment of pain. And I think we're going to have a lecture that goes into depth a little bit more about that. But this I recently submitted to the Department of Health. This is something that has been studied widely. And everyone can argue about the levels of evidence, but these are 5 of my highest quality randomized double-blind control studies related to medical cannabis and neuropathic pain. And so this evidence exists, and you have to look for it. This is a great study that was done by Donald Abrams, UCSF, that there is a synergy with opioids, right? That providing pain relief with lower opioid doses and less side effects without changing the opioid levels in the blood. This is kind of a little bit of a discussion. I'll skip over a little kind of quickly, but in the United States, usually more is better. And this is actually a fascinating study and something we talk about at our dispensaries. You don't want to just crank up the levels of THC. There is a sweet spot for each patient that's very different and very nuanced. And there's actually evidence showing that if we go too high, there's going to be an increase in side effects. So that's something that our pharmacists work with patients on, is to try to find that sweet spot. When you've gone too far and entered into side effects, then you've passed that sweet spot and need to come back. And this is something heavily debated, and there is evidence on both sides of the story here, but we certainly see this on a daily basis. We have a biased sample of patients that make it to our dispensary, but one of their main goals is usually to get off opioids. And this is just evidence done in 2016 that 64% of these patients did have a decrease in their opioid use, with 45% showing improved quality of life. And I certainly think right now cannabis is used as a last resort. I certainly think in the future we're going to be using this on all steps of that analgesic ladder. And I bet a lot of you are familiar with this and how we treat pain in the medical community. I think it's a tremendous adjuvant in many of those areas of the ladder. Anyone here familiar with numbers needed to treat? Numbers needed to treat, NNT. Yeah, this is something I'm a big fan of and share with all of my patients. In medicine, the numbers needed to treat are the number of patients that we have to treat for one to improve. And so it's not a number we talk enough about, and we're gathering more studies to have this. And there's actually a website called the NNT, and that helps us to put in context. There are some drugs that you have to treat 3,000 patients for one to improve, right? And this puts that in context of how many patients actually have to be treated with painful sensory neuropathy. Apologize for the capital Y, not sure how that happened. This is from the AMA Ethics Virtual Mentor. And you'll see cannabis, it's right up there. The only thing that beats it are tricyclics with a tremendous amount of side effects. And this is what I start to get excited about as a board-certified physician as we delve into the research, and you see that cannabis stacks up with many of these other treatments that we commonly use and are even FDA approved for the treatment of these diseases. This is, again, very biased research. Apologize for this. These are the patients that came to our dispensary in Minnesota. So they have a severe disease, they went to see a provider, they got certified, they got their certification in the mail, they came to our dispensary, they paid in cash for the medicine. But of those patients that are intractables, 24 plus 66, 90% of them are mild to moderate to significant benefit. So 90% of our patients that are making it through this process are benefiting from medical cannabis. Pretty interesting. And then I'd like to talk, anytime I speak about a medication, there's a shadow side, right? And we don't talk about it enough, and medical cannabis has that as well. There are contraindications. These are the only absolute contraindications, which are acute psychosis, other unstable psychiatric conditions. There are relative contraindications I don't think we're talking about enough. Someone with a recent myocardial infarction or a heart attack should not be started on medical cannabis. Somebody with a severe history of arrhythmias, obviously someone in an ICU should not be started. But there are also a lot of cautions, and that include breastfeeding, pregnancy, obviously anyone under the age of 21. There has to be a real close discussion on risks, benefits, and alternatives for anyone under 21. And then drug interactions. And that's something that we're talking about more and starting to examine a little bit more, that there do exist drug interactions between cannabis. And that's why I think even more reason to have a medical model, to have health professionals involved, that a provider, your physician is involved in this decision-making process. And this is just a slide on the cardiovascular side effects. Again, if you have a strong cardiovascular history, you should very closely weigh the pros and cons of utilizing medical cannabis. But there are also great studies, a year plus and even longer than that, that show medical cannabis is an incredibly safe therapeutic option. And this is honestly, one of the big things that got me involved in this as a physician. And at our dispensaries, the mantra is to start low, go slow. And I talked a little bit about this sweet spot. So oftentimes we are going to start at a dose where we expect a patient to feel nothing. And that shouldn't deter a patient, and the downside of that is cost, which I will get to here in a second. But we're going to titrate you up until there is that therapeutic window. The hard part about cannabis is that therapeutic window can be incredibly wide. A person my weight could benefit from 2.5 milligrams of THC or could take 1,800 milligrams of THC, and there's a wide range of that. But we try to creep someone up to that lower end of the therapeutic range and stop there. When we've gone past that, that's when you develop side effects. And one thing that's very interesting about medical cannabis, and I don't see with other drugs, is that this therapeutic range can widen as you're on medical cannabis as a treatment. And the body gets used to side effects faster than it develops tolerance to the medication, which is also a fascinating area of medical cannabis that I look forward to researching more. And this was, really what turned me as a physician. LD50, has anyone heard of that? LD50 is the lethal dose 50. It's mostly studied in mice, but it's a dose at which 50% of those mice will die. So it's a pretty hard stop that is going to kill 50% of the population, in that case mice, and we extrapolate that to humans. This is a little bit of a different graph where we put the LD50 over the usual accepted dose. And you'll see common things like codeine have a very minimal LD50 compared to medical cannabis or marijuana as it's listed here. And this is one of the things that really, piqued my interest, is that there's been no documented lethal toxicity from medical cannabis, meaning that a lethal overdose is impossible.
Why do you think the federal government's having issue with this? Medical level versus...
That's a whole nother lecture. Yeah, no, there's a lot of reasons for that, and I try not to get into that. I just try to keep to that evidence, and we are utilizing it, and the tide is changing quite a bit. And I know we're getting short on time because Jim's standing up. The difference, in the brainstem, there are not receptors for medical cannabis. So a lot of what we're seeing with the opioid overdose, and even I think opioids are the tip of the iceberg. We don't talk enough about NSAIDs and the potential side effect of NSAIDs, that I think this is going to be a tremendous therapeutic option that we should explore and at least discuss at the table when we're discussing therapeutic options at our visit. And this is a talk of cannabis use disorder, right? And there is a 9% of patients, this is in an illegal model that this research was done, that have tried medical cannabis that can potentially develop addiction or a cannabis use disorder. So there is a shadow side, and we need to learn from lessons in the past and set this up in the context of a medical model and beware of those patients that might go on to abuse this. But cannabis does not kill patients. This is the main thing that really turned me as a physician, and now 2.5 years later to be doing this, is to see how patients are benefiting from this medication. It's been shown to be effective for the treatment of chronic pain, neuropathy with the highest evidence, very well tolerated side effect profile, works synergistically with opioids. And as the medical community, we should really be the first in discussing this and deciding whether this is an adequate treatment for our patients or not. Thank you.